Friends, I welcome you all for the last day, or I can say the final day highlights of ESH 2023, which recently completed in Milan. And I will discuss some important trials which discuss on the final day in ESH. And definitely, I will hopeful that these trials, their results and conclusion will help us, all of us, to our day-to-day practice. So first of all, I am going to discuss the sub-study of URA study. You all are very much aware that in 2020, this trial is published. This shown that the serum uric acid has significant relations with the MACE event in a patient of cardiovascular disease. In the URA trial sub-studies, this sub-studies try to analyze patient serum uric acid level as well as the triglyceride level with the clinical event and their relation with the plaque in carotid arteries. So as we all are aware that the serum uric acid level, which not definitely higher, but is even in the higher normal range, may related to the MACE event, higher MACE event. And when we combine the serum uric acid as well as the triglyceride level, and when try to analyze the atherosclerosis in the vasculature, is significantly associated with the both of the biochemical markers. So in this sub-studies, the authors analyzed 6,200 patients which follow for the 20 years, and these patients divided in 4 groups. Some patient had the higher triglyceride level, which defined as the more than 150 of the TG level, and high serum uric acid level, which is more than 5.6 for male and 5.1 for the women. So almost 28% of the patient of this study shown that they had the carotid plaque when we screen for the carotid ultrasound, and these 28% patient has significantly higher level of the serum uric acid as well as the triglyceride, which has the predicted value significantly higher. When we come to the uric acid, its hazard ratio is 1.09. And when we come to the triglyceride, it is the 1.24. So when we divide these patient in the population which has the normal value of the both uric acid as well as the triglyceride, the incidence of the incidence rate of the plaque is 23%. When we analyze the patient of the serum uric acid higher and normal triglyceride level, the incidence is 31%. And when we have the patient who has the high triglyceride level but serum uric acid is normal, then the incidence is 34%. And interestingly, when we had both biomarker higher than the normal, the incidence rate is 38%, which is significantly higher in comparison to other groups. And logistic regression analysis also shown that the patient who had the higher uric acid level with normal triglyceride has the hazard ratio 1.15. When patient has the high triglyceride level, this hazard ratio is further increased by the 1.305. And when we have the patient with the combination of the higher value of uric acid as well as the triglyceride, the hazard ratio is somewhat more higher than the previous one, is 1.5, which is significantly higher for the rest of the group to predict the plaque burden in the carotid vessels. So as we all are aware that in the URA study earlier, we shown that the serum uric acid level is predicted the MACE event. And in this sub-study, we can also see that the serum uric acid level is independently associated with the presence of carotid plaque, which indirectly or directly leading to the higher cardiovascular event or MACE event, and combination of the higher level of the uric acid as well as the triglyceride is better predictor of the plaque formation in the vasculature, especially in carotid. So patients with higher level of uric acid as well as the triglyceride may predict our future event rate in the vasculature of the carotid as well as the coronary arteries. So now I am coming to the second study, which is an interesting study. We all can say that we try to analyze frequency of medical outpatient visit and use of home blood pressure monitoring in hypertensive patient in 5 European countries. So as you all are aware, ESH also they recommended the particular follow-up pattern, how we can follow the hypertensive patient. But we all are aware in all over world, the follow-up pattern is quite different. It's different between the countries, it's different between the different geographic areas. So in this studies, researchers try to assess prospectively the patient frequency in outpatient visit in hypertension patient who already on taken treatment, and use of the home blood pressure monitoring in 5 European countries. And these are the countries which include the France, Germany, Italy, and Spain and UK. And these data taken from January to March 2022, where we analyze how these patients following up in these different countries. So about 2,700 participants participate in this study. 46% were women and 94% patients older than the 60 years. 71% participant has the hypertension duration more than 5 years. 95% of participants treated for mean drug of the 1.7, and I can say that the more than one drug in all the patients already having. Overall, participants took average 4.1 pill per day. So we can say these are the patients who have the multi-morbidities or polypharmacy in their day-to-day practice. Outpatient visit frequency varied from 3% to as high as I can say that 30%. It depend on the different places or countries. So about 3% patients following their outpatient visit every monthly, 23% every 1 to 3 months, 28% every 3 to 6 months, and 30% every 6 to 12 months, and 13% patient less than a year. There was a significant countrywide variability. We can say that the patient of UK has least follow-up frequency, which is as low as 5%, and Germany has the highest follow-up visit, which is 21%, and the highest in the France, which is 42%. And 67% of participants perform blood pressure monitoring at their places, and only 30% required the external help. And home BP monitoring was done regularly by the most of the patients. 17% doing this daily, 26% several times a day or week, and 37% 7 times a month. So we can conclude that the recommendation of the ESH not following exactly even in the Western world, the day-to-day practice or the frequency of the follow-up is different in the different countries, and it's depend on the health facilities of that local area. But we all should focus that we have to follow a particular pattern of recommendation of ESH protocol, and adherence of this protocol may have better outcomes or better cost-effective treatment of the hypertensive patient. And now I'm moving to third study, very interesting study, which known as the Northern Shanghai study, in which association of the major adverse cardiovascular event and all-cause mortality with specific left ventricular geometry is assessed in elderly patients. So in this study, authors try to investigate that the left ventricular geometry effect on cardiovascular outcomes in elderly patients. So in this study, very interesting study, more than 3,300 patients from Shanghai is included, in which majority of patients are elderly, average age is 17.1 year, and about 56% were female. Echocardiographic parameters of all patients assessed, in which left ventricular mass index, which is 115 gram per meter square for male and 95 gram per meter square for female, is the average value, and relative wall thickness above 0.42 were considered as the abnormal, and patients were classified in 4 groups. One is the normal geometry group, which has the normal LVMI and normal relative wall thickness. Then second group is the concentric remodeling group, in which the normal LVMI and increased relative wall thickness. Third group is the eccentric hypertrophy group, in which increased LVMI and normal RWAT. And fourth group is the concentric hypertrophy, where both LVMI as well as the RWT is increased. And when we categorize the patient in these different four categories, we try to assess the cardiovascular death as well as the non-fatal myocardial infarction and stroke in relation to the different LV geometry of the elderly population. And the interesting result of this study shown that the mean left ventricular mass index was 87 gram per meter square, and relative wall thickness is about 0.39 millimeters. During the median follow-up of the 5.4-year, 224 MACE event has happened and 233 deaths reported. And when we analyze the all-cause mortality, which was significantly higher in patients of the eccentric hypertrophy in compare to the normal geometry, and when we try to assess the incidence of MACE, which are significantly higher in both concentric hypertrophy as well as the eccentric hypertrophy, but it's not higher in the patient of the concentric remodeling. So we can say that the higher the abnormalities in LV geometries, the incidence of the all-cause mortality as well as the MACE event is higher in comparison to patient who has a borderline abnormality. And baseline LV mass index is significant predictor of the all-cause mortality, and it's also predicting the non-fatal myocardial infarction and stroke or cardiovascular death. So we can now conclude that the patient in elderly patient left ventricular mass index as well as the relative wall thickness can predict their outcomes, and if patient has the higher abnormality in form of the eccentric or concentric hypertrophy, these are the patient has the higher all-cause mortality as well as the MACE event. And we can also conclude that the increase in the 10 gram per meter square in the left ventricular mass index can add 5% risk of the all-cause mortality in our patient. Now moving to next study, which has the impact of COVID-19 pandemic on blood pressure control in patients treated with hypertension, result from the European Society Hypertension study. Again, it's an interesting study, but we all are aware that the COVID pandemic affected our patient of hypertension, or I can say that every disease patient are affected. Their control or their follow-up is hampered, and it's also shown in this study also. So in this study, the 32 European center included, where the patient divided in two groups, in which the group 1 patient are included who visited to the hospital during the pandemic as a visit 2, and visit 1 is considered at least 9 to 15 months prior to visit 2. And group 2 are the patient who normally visited before the pandemic, and their visit 1 is at least 9 to 15 months before the pandemic. So we can say that the patient who visited at the time of the pandemic included in the group 1, and patient who had follow-up before the pandemic of the both visits included in the group 2. So almost 3,300 patients with the ambulatory blood pressure measurement were collected in from the 1,600 patients, and 50% about participants are male. Group 1 consisted almost 759 patients, and group 2 consisted 933 patients. And we can see that in the result, beta blocker showed a significant decrease between the visit 2 and visit 1 in group 1, definitely due to the respiratory illnesses. So patient of the COVID pandemic, every physician tried to stop beta blocker in most of the patients. At the visit 1, no difference were found in the BP phenotype or hypertension control rate between the study group. But at visit 2 in group 1, which done during the time of the COVID pandemic, there is a significantly higher of BP in compared to group 2. which has the higher systolic as well as the diastolic blood pressure. So we all are aware that during the pandemic, the compliance of the patient is poor. Patient has a higher rate of the anxiety and compliance again hampered. Patient could not be able to regularly follow their treatment. So the patient has the higher value of the systolic as well as the diastolic blood pressure. Higher 24-hour daytime as well as the nighttime systolic and diastolic blood pressure was observed in group 1 patient who visited at the time of the epidemic. And the prevalence of uncontrolled hypertension is again higher in the group 1 patient who visited during the pandemic. So these are the data. We all are aware that during the COVID pandemic, patient has the uncontrolled office as well as the ABPM pressure due to the poor compliance or poor follow-up. Again, interesting study of antihypertensive treatment evaluation in multi-morbidity and polypharmacy trial, a randomized controlled trial attempt which tried to answer the question that in patient who had the polypharmacy, who had the multimorbidity, how we can treat the patient and how the antihypertensive treatment protocol should help the patient. So in older patient who has multiple disease with having the multiple drugs during the management, how the patient should be treated. These are the patients who maximum trial excluded this patient. So this is the interesting slide to give you insight about particular treatment of these patients. So in attempt was a home-based 2-arm parallel partially blinded randomized controlled trial in which individual more than 65 years was enrolled who had the multimorbidity, at least 3 or more chronic condition, or polypharmacy, 4 or more type, 5 or more type of the medication, and who had the systolic blood pressure more than 115 to 165 range. And these patients recruited in this study. And this study shown that the decentralized design of the attempt enabled to participation of older, mostly non-hypertensive individual with multi-morbidity and polypharmacy from home. The remote intervention led to the meaningful reduction in systolic BP with no effect on quality of life or cognition function. And lastly, the prescription of single pill antihypertension combination therapy, how it can be helped. We all are aware that the hypertensive patient, if we use the combination therapy, it's in multiple trials, it's shown that this has the beneficial effect, it's cost effective, it's improving the compliance of the patient, and it's helping us to achieve the goal. And single pill combination therapy, how is going to help our patient is try to address in this trial the need of the polytherapy in common among people affected with the arterial hypertension. A single pill combination is a response to decreased medication adherence, especially in the elderly population who are suffering from the multimorbidity and who had the polypharmacy. In this studies, 148 participants were prescribed single pill combination therapy, and participants taking has a lower presence of the CKD in comparison to rest of the patient. No significant difference was found in presence of the diabetes mellitus. Another interesting finding was frequent use of SPC therapy among patients who have the higher BMI. So we can conclude that in case of the hypertensive patient who has the comorbidity of the CKD, usually SPCs are not available, especially for this population, because of the certain group of antihypertensive medication are contraindicated in the CKD patient. But when we in diabetic patient, this SPC can commonly use, and in the higher BMI patient also. So the results showed that less than the half of the participants in this study were prescribed on the SPC. From this, you can conclude that the more attention should be paid to educate people about the option of antihypertension treatment and simplify the therapy regimen, so you can help maximum patients and improve the compliance of these patients. and very limited options are available for the patient who are suffering from the CKD in form of the SPC. So we need to reinvent these combination therapy for the in view of the CKD patient. So thank you all for this summary of the ESC final days. Hope you all find it interesting. Thank you very much.